2023 Journal Club, and this is obviously the July issue, and the theme is aged care. So very lucky, we're going to have two excellent presentations. There will be time for questions, and I encourage you to write your questions into the chat line. If I can introduce first Dr. Lyn-Li Lim. Lyn-Li is an infectious diseases physician at VICNISS Doherty Institute with an interest in healthcare-associated infections and antimicrobial stewardship. She is involved in the research, development of clinical guidelines, and educational information in the areas of infection prevention and control and infections. She has a special interest in AMS in Australian aged care facilities with a focus on promoting quality use of antimicrobials and implementation of evidence-based practice. Thank you, Lyn-Li.
Thanks very much for that introduction, Noleen. Today, I thought I would bring to the group and talk about the ALTER study and what the outcomes mean for management of recurrent UTI in older people. As we know, urinary tract infections are one of the most commonly diagnosed and treated infections in community settings, hospital settings, and in residential aged care. And there is a myriad of options available in terms of treatment and prophylaxis of UTI. Some of them are available by prescription, but as you can see here, a lot of them are also available over the counter. Today, I'll be talking about HIPREX. And the ALTER study. So this ALTER stands for Alternative to Prophylactic Antibiotics for the Treatment of Recurrent UTIs in Women. It was a study that was published in BMJ early last year. So what is HIPREX? Well, HIPREX is also known as methenamine hippurate, and it's been around for a long time, since the 1970s. It's renally excreted, and the salts undergo hydrolysis into formaldehyde, which harbors the bactericidal properties. The hippuric acid component further acidifies the urine, which promotes hydrolysis of the salts, so makes the salts more effective. And the hippuric acid component also has a bacteriostatic effect. And why there's been a lot of interest in terms of use of HIPREX for the prevention of UTIs is that it doesn't contribute to antibiotic resistance. So a Cochrane review was published in 2012 looking at HIPREX for preventing UTIs. And at that stage, they included about 13 studies into their review, and that included about 2,000 participants. In their commentary, they identified issues with the design of some of the studies and also with how the analysis was conducted. And that led them to conclude that HIPREX may be effective for preventing UTIs in patients without renal tract abnormalities, particularly when used for short-term prophylaxis. HIPREX does not appear to work in patients with neuropathic bladder or patients with renal tract abnormalities. The rate of adverse events was low but poorly described. And they went on to say that there was a need for further large, well-conducted randomized controlled trials to clarify this question. So what do some well-recognized guidelines say about the role of HIPREX? The therapeutic guidelines says that the evidence for HIPREX for the prevention of UTIs is poor and inconsistent. It may reduce the incidence of symptomatic UTI in women without urinary tract abnormalities. However, further research is needed before it can be recommended. And HIPREX is not effective for the prevention of UTIs in patients with urinary tract abnormalities. AMH says in the counseling section to avoid taking medications such as sodium bicarb, urel, or citrovecin because they make HIPREX less effective. And in their practice point section, they point out that the evidence for efficacy for preventing UTIs is poor. It's not effective for suppressing infection with people with IDCs, preventing infections related to Proteus or Pseudomonas, as these organisms increase urinary pH, inhibiting the production of formaldehyde. It's not effective for treating UTIs. and a urinary pH of less than 5.5 is required for its activity. And the use of ascorbic acid may lower urinary pH, but because it has a short-lived effect, it probably doesn't work to increase the effectiveness of Hiprex. So on to the ALTAR study. What the study aimed to do is determine whether Hiprex was an effective alternative to the standard treatment of low-dose antibiotics for prophylaxis of women with recurrent UTI. And this to do that, they proposed to test the null hypothesis that Hiprex was inferior to daily antibiotics for the prevention of recurrent UTI in women. And in this study, they defined recurrent UTI as repeated UTI with a frequency of at least 2 episodes in the preceding 6 months or 3 episodes in the past year. And episodes were defined as self-identified symptoms, and so no microbiology confirmation was required. It was a multi-center study undertaken in the UK from 2016 to 2020. Participants were randomized, but it was an open label trial with no masking of participants, clinicians, or local research staff. And the way it was designed is months 1 to 12 would be the treatment phase, where people would be randomized to treatment with either Hiprex or antibiotics. And then months 13 to 18 would be an observation period. The participants came from women from secondary care urology and urogynecology centers around the UK. Inclusion criteria is that they had to be adults and they had recurrent UTIs and decided that prophylaxis was what they wanted. Exclusion criteria were women with urinary tract abnormalities and bladder dysfunction. Women already taking antibiotic prophylaxis or Hiprex were allowed to take part, but they needed a washout period of 3 months before randomization. Randomization was undertaken in a 1-to-1 fashion to either receive antibiotic prophylaxis or Hiprex. They also stratified by recognize what they deem were potential risk factors for recurrent UTI. So they stratified by menopausal status. So women were grouped into premenopausal versus peri or postmenopausal, and also by UTI frequency in the preceding year, whether they'd had less than 4 or more or 4 or more. And the arms they were assigned to were antibiotic prophylaxis or Hiprex 1 gram BD. And an antibiotic prophylaxis arm, they could either receive nitrofurantoin, trimethoprim, or cefalexin. And the decision on which one they were to be given would depend on previous urine cultures and their history of allergy or intolerance. Participants were allowed to switch between antibiotic drugs or between treatment strategies. And if they experienced symptomatic UTI episodes, they were advised to seek treatment courses of antibiotics in the usual way via their GP. So outcomes that they looked at, the primary clinical outcome was the incidence of symptomatic antibiotic treated UTI episodes that were self-reported by participants over a 12-month period. And an episode of UTI was defined as the presence of at least 1 symptom reported by patients or clinicians from a predefined list produced by Public Health England, along with antibiotics being prescribed for the episode. The end of 1 episode was defined as 14 days after the final dose. If symptoms restarted or further antibiotics were prescribed within this 14-day period, this was counted as the same episode. Secondary outcomes that they looked at were incidence of symptomatic antibiotic-treated UTI in the 6 months after treatment, so the months 13 to 18, microbiology confirmed UTIs, antibiotic resistance profiles in E. coli isolated from urine and perineal swabs, asymptomatic bacteria, total antibiotic use, hospital admissions due to UTI, and participant satisfaction with treatment assessed from 4 domains of satisfaction: effectiveness, side effects, convenience, and then an overall global satisfaction domain. Follow-up assessments were every 3 months until month 18, and at each visit, participants were asked about recurrence of UTIs, treatment adherence, adverse events. Blood tests were taken for kidney, liver function, and urine samples. And this was optional, but participants could also have perineal swabs submitted at baseline and 6 monthly routine visits. At the time of symptomatic episodes, so breakthrough infections, urine samples were encouraged, but in the UK, guidelines for adult women in the community is that microbiology confirmation is not necessarily required. And at the time of episodes, participants also completed symptom questionnaires. The analysis, the trial was powered to assess non-inferiority of the absolute difference in UTI incidence over the 12-month treatment period. And the non-inferiority margin was defined after a series of patient focus group meetings. And they determined that a difference of one UTI episode per year would be clinically significant for them. In the sample size, the following assumptions were used: the relative risk of UTI with antibiotics at 0.15, relative risk of UTI with Hibrix at 0.24. And then they also undertook a local audit of untreated participants to determine how likely they were to have episodes per year. And in their cohort, they determined that they would probably have an average of about 6.5 episodes per year. So using that data, they determined that 87 participants were required in each arm to be 90% sure that the lower limit of a one-sided 95% confidence interval above non-inferiority limit could be tested. And then they also built in an estimated 25% dropout rate over the course of the trial. And then that led them to end up with a target sample size of 240, so 120 in each arm. So on to the results. So if we compare the antibiotic prophylaxis and the Hibrix groups, we can see that they were well matched for age, menopausal status, number of reported UTIs in the previous 12 months before entry, number of positive urine cultures in the previous 12 months, and also previous use of antibiotic prophylaxis. So just point out in terms of the number of self-reported UTIs in previous 12 months before entry, the mean in this cohort, the study cohort, sits at about 6.8 to 7 episodes in previous 12 months. And in terms of previous use of antibiotics, about a quarter of the participants had previous use of antibiotic prophylaxis. So with the randomization, about half received nitrofurantoin, a quarter trimethoprim, and 20% cefalexin. And switched during that was in protocol during the study. 18% of participants in the Hibrix arm switched to receive antibiotic prophylaxis, and 6% in the antibiotic prophylaxis arm switched to receive Hibrix, but that was in protocol. So if we look at the modified intention to treat analysis, we end up with 205 participants, and the numbers that were included in antibiotic and Hibrix arm were similar. So if we look at the primary outcome, take a look at the figure. What we can see is in terms of the incidence of symptomatic antibiotic-treated UTIs over a 12-month period, if we look at the Hibrix group, we've got 1.38 episodes per person per year. And that was with a 90% confidence interval of 1.05 to 1.72. In the antibiotic prophylaxis group, we saw 0.89 episodes per person per year, and that was with a confidence interval of 0.65 to 1.12. And that leads us to the conclusion that the absolute difference between the antibiotic arm and the Hibrix arm was 0.49. So that's that line across with the diamond in it. That diamond indicates it's 0.49, and the length of the line is the confidence interval, which extends from 0.15 to 0.84. So with that finding, what we are able to say from the study is that with an upper limit of a 90% confidence interval before non-inferiority limit of 1, so it didn't cross 1, we can conclude that Hibrix is non-inferior to antibiotic prophylaxis in this setting. And then they went on to do a sensitivity analysis across different populations. So they ran it with a strict intention to treat or per protocol, and post-hoc strict per protocol, and they found the same result. In terms of secondary outcomes, so the UTI incidence in the 6 months post-treatment follow-up period, the absolute difference between the antibiotic prophylaxis to HIPEX groups was 0.53 with a 95% confidence interval of minus 0.03 to 1.0. So there didn't appear to be a difference. And 80% of 231 UTI episodes reported in the modified intention to treat population were accompanied by a urine sample. And during the 12-month treatment period, a positive urine culture was observed in 52% of these episodes. So what that means is of people that did, when they reported symptoms, did send in a urine culture, about half of them were microbiologically confirmed. In the 6 months after treatment, 66% of episodes were accompanied by a urine sample, of which 70% were positive, microbiology confirmed. A post hoc analysis of urine samples submitted during the 12-month treatment period identified a significantly higher rate in the HIPEX group than in the antibiotic prophylaxis group. So the difference, absolute difference was 14% versus 7%. And so what that suggests is if we look at microbiologically confirmed episodes, there might actually have been superiority or fewer episodes in people on antibiotic prophylaxis versus HIPEX. So therapeutic antibiotics for UTI, during the 12-month treatment period, about 43% of them had a breakthrough episode where they needed treatment for UTIs, and 56% in the HIPEX arm. And in the 6 month observation period, the total number of days taking therapeutic antibiotics was higher. Interesting, it was higher in the HIPEX group than the antibiotic prophylaxis group. With respect to antimicrobial resistance, I draw your eye to the first figure, which looks at the proportion of participants with any resistance in E. coli isolates. And the purple column is the group that's on antibiotic prophylaxis, and the orange column is the group that's on HIPEX. We can see at baseline, there's no difference, but at months 6 to 12, the people on antibiotic prophylaxis had more identified antimicrobial resistance. And this with no change in the observation period when they came off antibiotic prophylaxis. The next figure looks at proportion of participants with multi-drug resistance in E. coli. And we can see that at baseline and month 6 to 12, there didn't appear to be a difference. Month 18, there might be a difference, but the numbers were small between the antibiotic prophylaxis and HIPEX group, with higher antimicrobial resistance in the HIPEX group. And that might relate to the fact that that group had more breakthrough episodes or more episodes of symptomatic UTI and were hence exposed to more antibiotics. Looking at this data by agent, nitrofurantoin, trimethoprim, cefalexin, there's really not much to draw from it, apart from I would say that the rates of resistance in to trimethoprim in UK are high, and rates of resistance against nitrofurantoin are low, and that's probably quite similar to Australian setting. With respect to treatment, satisfaction was high and generally comparable between groups, and adverse events were low and comparable between groups. So overall findings, to summarize, in adult women with a mean age of 50 years and 60% in the peri or postmenopausal group who experienced 4 or more UTIs in the previous 12 months with a median of 6 episodes, and also with no reversible urinary tract abnormality or neurogenic bladder, as had been investigated by neurologists. In this particular cohort, 12 months of HIPEX is not inferior to antibiotic prophylaxis in reducing self-reported episodes of UTI, where what was seen as clinically significant was a reduction of 1 UTI episode per year. And it was also not inferior to antibiotic prophylaxis in terms of treatment satisfaction. With respect to the question of whether it was non-inferior in reducing microbiology confirmed episodes of UTI, that was not proven. That wasn't shown in the study, and the study design didn't wasn't primarily designed for that. And with respect to antimicrobial resistance, we saw higher antimicrobial resistance with antibiotic exposure. So I think the study is useful, but it does raise ongoing questions. And the questions that come to mind for me are, do these findings hold for other patient groups, in particular older people 70 years or more? And do these findings hold for men, for example? And do these findings hold for people with structural and urinary tract abnormalities? So these questions are not answered, and I don't think we should be promoting the use of Hibrix until further data is available on these groups. What is the benefit of Hibrix? Well, I think the study does show that there is benefit in women with fewer with more than 6 episodes of UTI per year. But what if you're experiencing fewer than 6 episodes of UTI a year? And what is the benefit in people with difficulty correlating symptoms to infection? I know I've had some patients that almost have continuous symptoms that are similar, that can be mistaken for UTI. If that's the case, it's going to be very difficult for them to separate whether they're achieving any benefit from Hibrix prophylaxis or prophylaxis in general. And what is the risk of antimicrobial resistance to the individual and to public health? And what is the long-term safety of Hibrix? IMMERSE is another study that's actually currently recruiting. It's based in Europe, and I think it will provide more important information in this space. It's a randomized controlled triple-blind phase 4 clinical trial. And it focuses on women 70 years or older with recurrent UTIs, and these women are identified from a GP setting. And they'll be randomized to Hibrix or placebo tablets for a period of 6 months, noting that ALTA, the treatment period, was 12 months. And then they'll be followed up in a drug-free period of 6 months. The primary outcome that they'll be looking at is number of antibiotic treatments for UTIs during the treatment period. Thank you very much.
Thank you, Lyn-Li. If I can encourage everyone, just because I can't see, Leslie, you might be able to write your questions in the chat. But while we're waiting for questions, Lyn-Li, I just want to highlight to everyone that aged care naps consistently in our residential aged care facilities is showing that Hibrix is widely used. Just wanted to make that point. Lyn-Li, I have a question again, everyone. Please type away. Just what's your thoughts? I know that population, the cohort there were younger than the greater than 70s. And, you know, the idea that the therapeutic guidelines and AMH are sort of steering us away from it. How can we encourage our facilities to hold back on the use of Hibrix, knowing that it is widely used?
Yeah, I think it's difficult because recurrent UTIs or prophylaxis for UTIs is obviously an area where there is a need for effective solutions. And that's why there's a lot of reliance on Hibrix. The other thing is it's not terribly expensive and there are very few side effects. So it's, you know, as a consumer, these things probably are important in terms of how they make their decisions. Why I chose this as a topic to present is that this is a space where there's not been a lot of high quality data, but yet as a practice prescribing and people purchasing Hibrix over the counter to use, it's popular, it's a big business. So I think we need to acknowledge that you know there is a consumer need. I think that what's important though is consumers are aware of the data. Why even though it might work for some people, it might not work for them. And in residential aged care, or in older people, I'll say, as a group, we know that structural renal tract abnormalities and neurogenic bladder are far more common. We also know that the difficulty correlating symptoms to whether something works or not can be more difficult in this population. So I don't think as pharmacists, as nurses and doctors, we should be blindly saying to consumers, I know you've got a problem, but here's the solution. You know, we'll offer you this, and this we don't, and we think it might work. I think we have to be more careful in our language and what we say, and say that actually we don't know if it will work. And if you take it, you need to be aware that it might not work for you. And I think that if we have these conversations up front, then that will help when we have the next conversation in, let's say, a few weeks or a month to say, or a couple of months to say, did it work for you? Do you think it's helping? And then it will help the conversation with saying, well, if we don't think it's helping, actually, we should maybe be looking at stopping it. And so that's that de-prescribing conversation, because I know that in your NAPS data, you've also identified, aged care NAPS data, you've also identified a big problem is that when these prescriptions are started, they go on for a long time, and sometimes they go on, it's a lifelong prescription.
Correct. Yep, very much so. Thank you, Lyn-Li. I think you've answered everyone's questions. Lyn-Li, well done to you. I have to say, if anyone has further questions, Jo, we'll get Jo to present now if you want to get your presentation ready. But maybe at the end, if we still have time, we can come back to you, Lyn-Li, if there's more questions. But thank you so much. Interesting and relevant, particularly to aged care, knowing how much is used in that space. Okay. Okay, I'm assuming now everyone can see Jo's presentation. So I'll look to introduce Jo. Jo is a postdoctoral researcher at the Department of Aged Care, Royal Melbourne Hospital, and holds an honorary appointment at the Department of Medicine, Royal Melbourne Hospital, University of Melbourne. Her research interests include research into current practice and implementation of best practice care of the older person, in particular, people with cognitive impairment and those living in residential aged care. Today, she will be presenting on the project IMMERSE. Thank you, Jo.
Thanks very much, Noleen. Can everyone see the correct screen? So,
we can. Thank you.
Okay, thanks so much. Yeah, so today I'll be presenting on IMMERSE. That's the Implementing Effective Infection Prevention and Control in Residential Aged Care implementation research project. And I thought I'd start by talking a little bit about implementation research and using IMMERSE as a case study example, and then talk through our methods in a bit more detail and then the results. Okay, so what is implementation research and why do we need it? Well, implementation research, it aims to reduce or improve the evidence to practice gap. So what we know we should be doing, what best practice tells us to be doing, what the research tells us to be doing, isn't always put into actual practice. And there's some examples on the screen there of where inappropriate care is still going on in quite high numbers. These are just results of some systematic reviews that have been done. And the Australian study, look, it's getting a bit old now, but it found that 10 to 87% of care received was inappropriate. More recently, a Canadian study, systematic review, found that on average 30% of therapeutic and diagnostic management was inappropriate or reported to be inappropriate. So we need to obviously reduce inappropriate care and up the appropriate care, not only because of the costs and inefficiencies, but also can lead to adverse effects. Implementation science, so what is it? It's the scientific study of the methods to promote the uptake of research findings, so that evidence-based practice, into routine healthcare. And the science behind it is that the theories, the models, the frameworks that you might have heard of. Implementation research builds the body of evidence about whether any given strategy or implementation intervention is effective and cost effective. And I've just popped up the figure, the increasing evidence figure that you may be familiar with, where you might have some anecdotal evidence or preclinical, moves on to a definitive randomised controlled trial like Lyn-Li's just presented. And then we need to see, okay, we need to also put in some long-term implementation. So taking it out of that research context and into other settings that might be in the hospital setting, in primary care, and also thinking about not just scaling up, but also sustaining. So that's where implementation research comes in. The features of implementation research are different to your typical type of intervention research. So the subjects in implementation research are actually those who are providing care. So as Lyn-Li just presented a randomised controlled trial, the subjects were the patients, the women who have the UTIs. Whereas with IMMERSE, we're working with aged care staff, in particular direct care staff, cleaning and food services staff and lifestyle staff. So those who are obviously key to infection prevention and control in resi care. And we're working closely with infection prevention and control, or the IPC leads. For those who aren't familiar, the Australian government mandated that every facility, every residential care facility must have a nurse who's undergone some additional IPC training. And that was one of 3 courses that they have to have, either be participating at the moment or have completed. There's some issues with that, in particular around the workforce concerns or challenges in resi care. So there's a lot of turnover, in particular of registered nurses. There's turnover of about 50% at the moment. So just seems like a great idea, but there are some challenges. Going back to implementation research. So the objectives are to investigate or address an evidence practice gap. So you know that what's currently being done in practice isn't what should be done, isn't what the research is telling us should be done, or what the guidelines are telling us what should be done. So it's an investigation of that. And then also trying to put in place some intervention to improve that, to improve the uptake. The objectives of IMMERSE are to identify and address barriers to best practice infection prevention and control, quite a broad objective, but we are focusing on standard precautions, in particular hand hygiene, PPE use and cleaning of shared equipment. The measured outcomes of implementation research usually or almost always includes what the healthcare providers, healthcare workers are doing. So we do need to measure in some way the practice side of things. You can also measure, and it's often done, you're measuring the clinical outcomes as well that are clearly associated with that practice. So for example, hand hygiene and MRSA rates, just to give an IPC example. And the ultimate aim of implementation research is to build evidence about whether the implementation strategy works. With IMMERSE, we're taking a bottom-up approach, so we're focusing very much on the staff behaviour, the individual, as well as team-based behaviour. There is also a top-down approach, and you may have heard of use of audit and feedback or clinical pathways. There's sort of some examples of top-down approach, but I won't be talking much any further about those. The idea of taking a behavioural perspective is to first understand what the problem is before jumping to solutions. I think a lot of the time, and I've been guilty of it in my previous research, we assume, oh, they need more training, they need more education, and that's what we put in place. But in fact, there might be some other things going on that impedes the uptake of best practice. So we need to figure out who needs to do what differently, then what factors influence whether or not they do it. So that's where you might be investigating barriers and enablers to performing these behaviours. And a behaviour is just something that's an observable action. So that might be performing hand hygiene. Then we need to figure out which strategies can effectively be used to target those factors and how best to evaluate success of that implementation intervention. And I'll go into more detail in a minute with the IMMERSE project as an example. So IMMERSE is a multi-phase, a mixed methods implementation project. And it's although I've got the 4 phases in a nice neat row, there are things going on concurrently, in particular the community of practice work that we're currently working on as well. We've completed phase 1 and we're partway through phase 2. So in phase 1, it's really collecting baseline information about this concept about organisational readiness for change, which some of you may be familiar with. We were also interested in the IPC programs at the different residential care facilities, because there's actually not a lot of information about IPC programs in resi care. We've assessed current practice using scenario-based assessments to identify gaps in practice. And this is what we're up to at the moment, where we need to then interview the staff again to figure out why those gaps are occurring, so what the barriers are to translating these principles into practice. Then once we identify these barriers, we determine solutions, working with the staff and the IPC leads. And then the aim is we're hoping to upskill the IPC leads to facilitate the practice change. So we'll support them, we'll upskill them, and we're hoping that they'll be able to drive the change, because there's no point the research team going in and doing it all and then leaving. It probably won't be sustainable. At the same time, this is occurring at the moment as well, we're developing an IPC-led community of practice to support and share experiences. So for them to support and share their experiences. We've spoken to IPC leads a bit during the process of the research, and some of them feel a little bit isolated. There isn't a lot of guidance at the moment around their role. It's very much up to the facilities, the organisations at this stage. So yeah, that's just something else that we're working on. A PhD student, Robin Smith, is helping out with working with us on that, and it's very much a co-design process. Okay, so I thought I'd talk through what we've done so far. As I mentioned, that organisational readiness for change, we surveyed staff from 10 facilities, and we used an existing validated survey to do that. We had reasonable completion rates. So for anyone who works in the sector or who's done research in the sector, they're quite time poor. And at the moment, with the workforce challenges, there's staff shortages as well. So we recognise that that's a limitation, but we got reasonable completion rates, and we've tried to keep surveys and interviews fairly short as well, and within their overtime period. Sorry, not overtime, double time, not overtime. We found they actually had good to very good levels of efficacy and commitment to change. So that was quite promising, whether that's representative of the sector or it's a little bit of bias because the facilities have volunteered to participate in this project, so they've already got they're interested in being part of the project. But that was quite a nice finding. When we looked at the IPC program core components, so we developed a survey based on the World Health Organisation's recommendations around IPC programs, as well as the CDC. They've got a nice tool that they developed for long-term care. And it assesses things like policies and procedures, staff training and competency. I'll show you the next slide with the results that'll go through the details of that. Okay, so we wanted to know, and we surveyed the IPC leads and the managers first and asked them, do you have policies and procedures about standard precautions? Then we went to the facilities, this is just giving you an example, and we asked to see the procedures. In fact, we asked for copies of them. And we were also interested to hear from staff if they knew about these policies and procedures, how do they hear about them, do they know how to access them as well. But that's not represented on this table, but that's sort of the level of information that we were collecting. So they all have transmission-based precautions and standard precautions. 9 out of 10 had procedures around infection surveillance, and 8 out of 10 around antimicrobial stewardship. So we have fed this information back to each of the facilities individually. So I've put together a short report, and within that are some recommendations. And we also met online with the facilities to discuss the findings. So usually it was with the IPC lead and the manager, just to go through the findings, verify some things, make recommendations, suggest resources, those sorts of things. With regards to staff training and assessment, we wanted to know, do all staff, so all staff employed by the facility or the aged care provider, receive hand hygiene training, for example? And yes, 100%. I think a lot of that is a result of COVID potentially, but I shouldn't say that. We didn't ask that, but yeah. So that was good to hear. Not all of them have their hand hygiene competency assessed though. In the cases of the partial, one of the facilities had the nurses only have their hand hygiene competency assessed, and in the other facility, hand hygiene competency is assessed through hand hygiene audits. So it's not really that doing it of all staff, it's that sort of convenient sample. So yeah, that's why they sort of got a partial response there. PPEs training, again, 70%, so these are areas that could be improved. PPEs competency assessed amongst 50% of the facilities, and similarly with mask fit testing. The partial here, that meant that they'd started just doing the direct care staff, for example, or just the nurses or personal care workers. And 30%, so three of the facilities hadn't undergone mask fit testing, and that was usually around a resourcing and financial issue. We also wanted to know about their communication, so how they inform staff and family and residents about IPC and a practice change and what's going on in the facility. They all use multiple methods, so they're all using emails, SMS, and for family and residents, a lot of it is face-to-face. Same with staff, obviously at staff meetings and handover, they're conveying that information, as well as newsletters up on notice boards. Involving residents and family in IPC, we wanted to know, do staff educate, remind and encourage family and residents in IPC? And look, most of them do. Some seem to do it better than other facilities. And we interviewed residents and families about this. So some of the partials were where residents said, oh, we used to all have our hand hygiene, the alcohol rub passed around, but that sort of seems to have petered off. Or a couple of residents said they would like to be offered the use of a mask during group activities, but that's sort of not happening at the moment. So just things like that came up. Then with regards to that IPC lead position that I mentioned before, we wanted to know about whether there was a position description in place. So 6 out of the 10 facilities had a position description, and with permission, we've shared that position description with the facilities that don't have it. And then dedicated time for the role. Look, not many IPC leads have dedicated time for the role. I remember one of the facilities said, yes, I do have dedicated time, but I actually don't have time to do it. So that's where the partial came in there. A lot of them, the IPC leads when we interviewed them, they were also the clinical care coordinator or the most senior nurse within the facility. So they've also got a lot of other senior roles and other portfolios to fulfill as well. So they're very time poor, and with the staff shortages, again, this was an issue. With phase 2, we've done a document analysis of the national guidelines and also policies and procedures, again, focusing on those standard precautions. And we wanted to know, we assessed something called specificity, where we wanted to know, do the recommendations in the policies and procedures actually specify who needs to do what, with whom, where, and when. And that analysis is currently being undertaken. We also looked at current practice and used scenario-based assessments. And I thought I'd just share a couple of the slides. So scenario 1, we've got Mary. She's a resident with dementia and she's sliding out of the chair. What actions would you take? What IPC actions would you take? And we wanted to know really the decision making. So in the scenario of a resident sliding out of a chair, we don't expect them to necessarily have time to do hand hygiene because Mary's safety is a priority. And so we wanted to hear from them why they're not doing certain things or what's going through their thought processes at the time. Then scenario 2, and the scenario progresses on and involves multiple staff. And then scenario 2, we've got Antonio. He's in a group activity and he seems to be coughing a lot and seems unwell, not his usual self. So we wanted to hear from the lifestyle staff member what they were doing in that scenario. And then again, it progresses on where you have personal carers involved and nursing staff involved. And so, look, we chose to do scenario-based assessments because it's very hard and resource intensive to do observational audits, and also people kind of tend to behave differently as well. What we've found so far from our analysis, and this is just preliminary findings, we're doing a second coding at the moment, is that people are not always performing hand hygiene before donning gloves, in particular, donning PPE. And the other thing I heard at a couple of facilities was the use of gloves instead of hand hygiene. So that's a couple of areas that we're going to explore a bit further. And look, from the work that we've heard so far and in the scenarios as well, not always involving residents in infection prevention control, so that hand hygiene and wearing masks. And there are some examples in the scenarios as well around that. So that's what we're up to at the moment, the analysis. And the next steps, once we've identified clearly and prioritised what action we want to improve, so whether that's the hand hygiene before donning gloves, we are then going to explore barriers. So why is that occurring, and what factors influence whether or not they do it? So that will be through interviews, and we're using a framework called the Theoretical Domains Framework, the TDF. It provides a list of topics to explore. So we're exploring all these 14 constructs. It's based on over 20 years of behaviour change research. Then once we know the areas that need work, so if knowledge is an issue, then yes, education is the intervention function needs to include some education. But if it's about role and identity or social influences, then the intervention needs to include some modelling. If it's about beliefs about consequences and goals, and I have a feeling there's a little bit of that, persuasion needs to be included in that. And you can have multiple components in one intervention, implementation intervention. So we need to match the solution to the identified barrier, not make those assumptions. So that's what we'll be doing over the next 6 to 12 months. And yeah, we have a large research team, advisory group and reference group. So we have representatives from Carers Victoria, Dementia Australia, so carers with lived experience, Department of Health, the Victorian Department of Health, and also industry on our reference group. And this is an MRFF funded project. Sorry, I should have mentioned that earlier. We were successful in receiving one of the Dementia, Ageing and Aged Care mission grants. And very happy to take questions and also to be contacted about the project at any time.
Thanks, Jo. Always good to learn more about implementation science. We've got Yvonne's got 2 questions, and I believe Kaz, you've got a question but can't access the Q&A. So Kaz, did you want to unmute maybe and just ask your question first?
Yeah, I will. Thanks, Jo. So interesting. And, you know, I think this is an area of research that we need to do better in, understanding how and why we need to do things before we decide what we're going to do.
Yeah.
I mean, clearly we're an AMS team, and what AMS is in an aged care is obviously very different to what an AMS is in a, you know, public hospital. So I was interested in what it was that you asked about AMS.
We asked if they had specific policies and procedures around AMS and asked to see them, but we haven't assessed the content of those procedures. We just don't have the resources. But if anyone's interested in, you know, in particular a master's student or something like that, that would be a great research project as well. And the other thing we asked was around do they have an AMS program in place? And then in the interviews, I asked around the governance. So who's involved, like that sort of committee level, who attends that committee, where that information goes, that sort of level. Is that yeah, I didn't ask any specifics around practice.
It does actually sound like an ideal opportunity for a little project.
Yes.
So I think we'll put it out there. I think it'd be an amazing opportunity to look at that.
Yeah, we've got a lot of data actually. So if anyone has,
so I agree.
Please.
So contact you.
Yes, contact me. Yep, definitely.
Great. That's wonderful, because I know that they're looking for honours and other projects. So this is an ideal one, I think.
Yeah, no, that would be great. Thanks, Karen. Yeah, I'll be in touch with you.
Yvonne asks, how do you become part of the community of practice for IPCs, please, Jo?
Okay, yes, we will be opening it up. At the moment, we're definitely including those 10 facilities if they're interested, and then we're hoping to open it up. We were originally thinking of just it was just going to be Victoria, just for the logistics of it, but we mightn't end up, we're not sure. It's all in the co-design process. So again, please contact me, and yeah, we'll start collecting a list of interested parties.
Yeah, what wasn't presented here, but what I happen to know, and in detail, the team have looked very closely at exactly what a community of practice is and how it can be sustained, etc. Jo, did you want to elaborate on the work that's been done?
Yeah, the work to date, we did a rapid review of communities of practice in residential aged care. We started off thinking, oh, we'll look at infection prevention and control in resi care, but there actually wasn't anything to that within that scope. So we expanded. We were interested to know how communities of practice can work in residential aged care. And there were a few Australian studies which was great, because we're able to, you know, the context is the same. And so, and we're able to contact those authors to learn from them. But a community of practice is generally made up of 3 core components. So the domain, the community, and the practice. And the practice is things like the resources and what's shared, the community of the members, and then the domain is that shared passion and shared interest. It seems that there's not a lot of conclusive research to say, put this in place and that community practice will be successful. There's not a lot of that. So yeah, not at the end of it, we didn't come away with, oh, this is how we're going to develop it. There was just so much. It was heterogeneity. They're just so different with the studies. But the model we're probably going with is where we'll initially facilitate it, but but develop it in a co-design way and in a way that could potentially where the members are leading it, rather than having, the research team come in and then leaving it fall. So we're already thinking about ways of sustaining it. But look, communities practice don't have to go on forever. They can be for a defined period for a particular objective. So if it was to develop an IPC lead position description, or particular modules or resources, that's what community practice can work together to do that as well.
Because we're most listened today have an AMS especially interest, maybe that's another practices that we could look at as part of the community of practice.
Absolutely. Yep. Look, the facilities, as you probably know, they're all collecting this data. I'm not sure they know what to do with the data, or they don't. What I did find was they don't seem to be sharing it with the staff on the ground. Now, and there's other, the infection rates as well. It's not necessarily shared with staff. So little things like that, could be helpful. They're just, things about sharing information. That audit and feedback can actually help change practice potentially. But Karen's got her hand up as well.
Okay, Yvonne's got a second question, just quickly. Sure. Where they were fit testing masks with machines or fit checking masks?
No. We asked about the machines.
Yeah, great. Yeah. And were they trained in fit testing outside the home, or just bought a machine and did it?
Yeah, there's a mix.
Okay.
There's a mix. Most just paid an external group. Yeah, and we've got two of the facilities are public health facilities. So
yeah.
They
had access that the others mightn't have had.
Yeah. Most have brought it in though. Yep.
Sure. Kaz, did you have another question?
Yes. No, I was just going to say, I'm assuming, because you've got Jill in your team, Jill France in your team, who is an international leader in audit and feedback methodologies. This is obviously a huge issue in how we communicate our information back to those people that need to know it, and so that they understand what they need to do. And we've just come out the back of applying for the implementation science trial MRFF with Denise O'Connor at Monash, and it was really great to sort of work through what that might look like. So that audit and feedback piece, obviously the TDF framework will be very helpful to understand how they might like that information. Jo, have you got anything to say yet about that, or too early?
Too early, but we have we have provided feedback on the baseline data to the facilities. We provided a report, and then a few of us, Noleen and myself mainly, and then Lyn-Li, then met with the facilities and we used, it was the audit and feedback research. We based some of the methods on that. So multimodal by an expert, so that's why Noleen and Lyn-Li were there. When people hear from an expert in the field, they're more likely to take things on board. That's just one example of what the research tells us around when you give feedback, and same with using multimodal methods. So that's kind of all we've done so far. I'm not sure if that answered the question, but it's something that we Jill reminds us all the time. So certainly something we're aware of, and we're making sure we are doing it in an evidence-based way, I guess. Yeah.
Fantastic.
Just mindful of the time, and I think we've covered everyone that wanted to ask a question. Jo, can you just instead of putting your slide up, maybe just speak to your email address if anyone wants to scribble it, and then Lyn-Li too. Apparently has dropped off for another meeting, but
we've got very similar email addresses. So I'm also happy for people to contact. I can't do two things at once. Sorry. Also, people can contact. Who organised this, Noleen? Courtney, wasn't it?
That's right.
Anyone from NCAS, I'm happy for my.
And we can pass it on. Absolutely.
Yeah. Also, I'm on Melbourne Uni's Find an Expert page, so I can always be contacted that way.
Good-o. Well, thank you, Jo. That was really interesting. As I said, really important. The more we learn about implementation science, So thank you so much.
No problem. Thanks for the
And thank you,
opportunity, everyone.
Thank you everyone for attending. NCAS Journal Club is held every month for those, this is your first time. So if you want to know more about the different sessions over the year, via Courtney is probably the best way to get that information initially.
Just jump onto the NCAS website.
Of course.
There's a tab called Webinars and Journal Clubs, and all our previous Antimicrobial Awareness Week and sessions have all been recorded, and there has been quite a bit of aged care stuff over the years, so we can certainly collate a few of the sessions and perhaps put out a tweet about or
good idea, Kaz.
Something around the ones to look at. I would say it's a slow moving field, Noleen.
Yeah, it is. But it is moving. I don't want anyone to feel disheartened. It is moving.
No.
Yeah, but we will keep, and also too, I guess, if you've got specific topics, related, obviously this journal club is for the most about infections and antimicrobial use, and antimicrobial resistance. If you've got specific topics relevant to aged care and other settings, let us know. We can look to try and source the experts to answer, to present. So thank you, everyone.
Thanks, Noleen.
Thanks, guys. Thanks,
Great
Jo
journal
and
club.
Lyn-Li.
Bye.
Okay.
Thanks.
See you,
Bye.
everyone. Bye.